Right, welcome everybody. We're just gonna let all the attendees get entered into the webinar. We'll get started in just a second. Go ahead and share my screen. Does that look okay on your end, Alex? Just okay, perfect. Okay, well, it is noon. Thank you everyone for joining us today. My name is Sarah Eaglesizer and I'm a nurse with OPEN, the Overdose Prevention Engagement Network. Welcome to today's webinar, Strategies for Screening, Diagnosing, and Treating Substance Use Disorders During Pregnancy. During our presentation today, audio and visual capabilities will be turned off for attendees to limit distractions. We do encourage you to ask questions of our presenter. Please submit your questions using the Q&A function on the Zoom toolbar at the bottom of your screen. Click on Q&A, type your question, and hit send. We'll address these questions as time permits during the Q&A portion at the end of the presentation. We are offering CME, Social Work, CE, and MCBAP credits for today's webinar. We will have a slide up with the information about how to obtain these credits at the end of the webinar during the Q&A. We will also email the CE information after the webinar today. The Overdose Prevention Engagement Network, or OPEN, is a diverse team dedicated to improving lives and reducing the harms of substance use. By engaging with individuals, communities, and organizations, we share education and resources to strengthen person-centered prevention, treatment, and recovery. With an overarching goal of developing transformative evidence-based solutions to reduce harm and stigma surrounding substance use, we work to support healthcare clinicians and communities in understanding and addressing substance use disorders at every level. We offer a variety of evidence-based services and resources for clinicians. We offer on-call consultation services to connect prescribers to our addiction medicine experts who can provide guidance for managing patients who have substance use disorders or complex pain. We offer expert-led education and training sessions, such as the one today. Most of our webinars offer continuing education credits, and for prescribers, all of our credits also qualify for the DEA required SUD training. We provide MOUD training for clinicians, and our next training is coming up on September 16th. This year, we are incentivizing primary care clinicians with a $250 incentive to complete one of our MOUD trainings. To prevent new persistent opioid use, OPEN established and continues to update evidence-based opioid prescribing and counseling recommendations. These recommendations are based on patient-reported outcomes after various acute care episodes and provide data to inform opioid prescribing. OPEN also provides tangible tools to reduce the harms of opioid and substance use. We encourage you to partner with us and apply for our programs. We offer a free library of evidence-based printable education materials for both patients and clinicians. Patient education materials can be co-branded for free and are available in English, Spanish, and Arabic. We provide safe medication storage and disposal options. We also offer overdose rescue support, including naloxone vending machines and distribution boxes, as well as naloxone administration trainings. OPEN understands that effectively addressing opioid use disorder and other substance use disorders requires deep collaboration and tailored solutions to meet the unique needs of each part of the state. We continue to provide regionally dedicated behavioral health consultants. Each work directly with clinicians, physician groups, and community organizations in your area to help build connections and networks locally. And with that, I am excited to introduce our presenter today, Dr. Alex Peel. Dr. Peel is an assistant professor and physician investigator in the Department of Obstetrics and Gynecology at the University of Michigan. Her overarching career goal is to improve the effectiveness, efficiency, and equity of reproductive health care, particularly for marginalized groups. She attended medical school at Northwestern University and a residency in obstetrics and gynecology at Brown University. Following residency, she completed the National Clinical Scholars Program, through which she earned a Master's of Science in Healthcare Research and Policy at the University of Michigan. She is a nationally recognized expert on pain management and opioid use in pregnancy, as well as prenatal care redesign and innovation. She is the director of the Partnering for the Future Clinic, which provides prenatal services to birthing people with substance use disorder. She also led the development of the Creating Optimal Pain Management for Tailoring Care, or COMFORT guideline, which provides comprehensive recommendations for patient-centered, equitable pain management after surgery and pregnancy and postpartum. With that, Dr. Peel, I will stop sharing my screen and turn it over to you.
Great. Thank you so much for that warm welcome. It is such a pleasure to be with y'all today. I am thrilled to share a little bit more with y'all on strategies for screening, diagnosing, and treating substance use disorder in pregnancy. Before we hop in, just a few disclosures. My funding is on the left, but perhaps more importantly is my personal disclosure on the right. I am a mom. I have a 3.5-year-old, and becoming a parent has really changed my approach to providing prenatal care and obstetric services more than any other experience. I also want to share that I am new to providing care for birthing people with opioid use disorder and substance use disorder. While I've spent many years working in the peripartum pain management space, it is only in the past year that I've been providing direct care for birthing people with substance use disorder. And so I look forward to sharing what I've learned with you and continuing this journey together over the upcoming years. So in the next hour, we have a lot to cover. We'll start with some background on the epidemiology and impact of opioid use disorder and substance use disorder in pregnancy. We'll then move into some guiding principles on providing effective, patient-centered, trauma-informed care. With that foundation, we'll move into how to identify substance use disorder in pregnancy through screening, and then the management. So let's start with why it matters. We face two concurrent crises in the United States. First, the opioid crisis, which this audience is very familiar with. In the US, there have been almost 650,000 deaths from overdose, and that has translated into the obstetric space with escalating rates of opioid use disorder in pregnancy and resulting neonatal complications with rates of neonatal opioid withdrawal syndrome. Simultaneously, we face a maternal morbidity and mortality crisis in the US. Birthing people today are more likely to die in the pregnancy episode than their mothers, and half of those deaths are occurring postpartum. We also see significant inequities in access, experience, and outcomes, particularly for groups that have been historically marginalized by race, racism, and socioeconomic status. These two crises intersect in the number one cause of pregnancy-associated mortality in Michigan, which is overdose related to opioid and substance use disorder. Just to put a point on this, almost 1 in 3 maternal deaths in our state are due to substance use disorder. And so if we want to start chipping away at adverse maternal outcomes in Michigan, we have to start with substance use disorder. The opioid crisis has changed significantly over the past 25 years. Over time, we've seen an evolution in opioid use disorder and overdose, from prescription opioid overdoses in the 90s to the increase in heroin overdoses in the 2010s, to the more recent rise in overdose deaths due to synthetic opioids. And we've seen this evolution mirrored in pregnancy. This is a retrospective review of pregnancy-associated mortality due to substance use disorder published in JAMA in 2022. And you can see how the substances involved in overdose deaths have increasingly involved fentanyl and stimulants. And you can also see the shift to increasing deaths in the late postpartum period. This is often a time after routine obstetric care has typically ended and is forcing us to rethink, when is our role in caring for our patients? Ongoing substance use in pregnancy is associated with adverse effects for both the birthing person and the neonate. And almost all of these adverse events, growth restriction, abruption, preterm labor, stillbirth, overdose, can be mitigated through routine prenatal care and effective treatment for opioid and substance use disorder. So, why doesn't everyone receive treatment? Birthing people with substance use disorder and pregnancy face particularly unique challenges in the United States. This includes the criminalization of substance use disorder, which in many locations is increasingly being driven by legislation that codifies the notion of fetal personhood. According to Pregnancy Justice, which is a nonprofit that seeks to document instances of pregnancy criminalization, the majority of cases brought against birthing people from 2006 to 2022 have occurred in states with legislation that defines child abuse as including fetuses, fertilized eggs, and embryos. The overwhelming majority of these 1,300 cases, 9 in 10 of them, are based in substance use allegations. This kind of legislation exists in 25 states and Washington, D.C., with even more states, 33, having punitive policies towards moms who are using substances in pregnancy. And this has real consequences. A claims-based study from 2017 to 2018 found that states that had policies that criminalize opioid use disorder and pregnancy have 1/3 of the rate of diagnosis of opioid use disorder. As a result, policies that limit access to diagnosis and treatment can also have downstream effects for moms and babies. In fact, current laws that require reporting by social workers, educators, and medical professionals create this truly terrifying environment for birthing people, where the very people who are in professions meant to help them can also take away what they care about most, their child. I think that this quote from Pregnancy Justice really summarizes it well. Contrary to claims that arresting and prosecuting pregnant people will encourage them to desist from substance use and thus improve maternal and fetal health, fears of detection and punishment present a significant barrier to care, causing some people to delay or avoid prenatal care altogether. And this creates a health risk since substance using pregnant people who do receive prenatal care have more positive birth outcomes and more opportunities for health promoting interventions. It is perhaps not surprising then that the number one reason that birthing people with substance use disorder do not seek prenatal care is fear. And there are some amazing advocacy efforts across the state and across the country to think about the best approaches to care for this population. But in the meantime, it's critical for us as healthcare professionals to recognize the context in which we enter these conversations with our patients. When considering context, it's also important to note that 80% of women seeking treatment for addiction report a history of physical or sexual assault, and that women with substance use disorder are 12 times more likely than the general population to experience PTSD or post traumatic stress disorder. So, as we think about providing care for this population, the how we provide services is equally important to the what. And so next, we'll review some of the basics of providing patient-centered trauma-informed care before moving into the specifics of screening and treatment. So how should we provide care? As I've increasingly served birthing people with substance use disorder, I've been struck by the critical role of empathy in supporting these individuals. And these quotes highlight the role that I see healthcare workers playing in this care. Kindness can transform someone's dark moment with a blaze of light. You'll never know how much your caring matters or makes a difference. And so I hope the tools in this section really provide a good foundation for bringing that blaze of light that helps patients keep coming back and continuing their path to recovery. I'll frame this section with a case. Stephanie is a G1P0 or a first-time mom, and she's at 22 weeks. And she's referred from an outside hospital emergency department to your clinic for prenatal care. She presented to the ER several times in her pregnancy, first for nausea and vomiting at 10 weeks, and then again at 20 weeks for abdominal pain, which was found to be consistent with round ligament pain. She reported that she was injecting heroin and her urine drug testing was positive for fentanyl and cannabis. Just taking a moment to pause, what do you think that Stephanie's experience was like in the ER? My patients often share with me quotes from their former healthcare team members, including clerks and nurses and doctors. They share things like, they told me I didn't deserve to have my baby. They asked me, how could you do this to your child? Or I was told that nobody would take care of me if I was using while I was pregnant. And so, with this context, what concerns do our patients walk through the door with? They're afraid of being talked down to, scolded, or even verbally abused. They're worried about the role of CPS, being treated as a criminal, or fear that we won't care for them. And in fact, this message is echoed through the media. We often see a sensationalist approach to addiction and pregnancy, with several TV shows providing really stigmatizing portrayals of substance use disorder in pregnancy. And for all these reasons, it's really critical to bring these guiding principles to care delivery. The use of careful language, trauma-informed approaches, harm reduction, and careful attention to social drivers of health. First, language matters, and many of these practices may already be part of your current interactions with patients, but I just wanted to highlight a few ways that language can be more welcoming, both in our interaction with patients, but also in how we talk about this population with the community. Person first language is critical. As you can see in the suggestions on the right, it recognizes the difference between an individual and their actions. In obstetric care, we're increasingly trying to be gender neutral in our terms, using birthing person or pregnant person rather than woman, recognizing the variety of gender identities our patient may come to us with. We often talk about populations that are hard to reach, but this places the onus on them. Talking about populations that are hardly reached instead suggests there's something more that we can do to reach out and meet people where they are. I think one that is hard often for us who trained as physicians is talking about treating with patients rather than doing treatments to patients. We're often taught that I'm going to start the patient on a medication, and it requires quite a frame shift to say, we're going to work together to make a plan for her care. And then finally, finding positivity in any encounter, really celebrating small wins, that the patient came back, that they overcame the 2 buses required to get here, can really help to set the tone, and telling stories of success and recovery rather than failure. These are some really nice examples from the SAMHSA resource guide, which you can access, that give great language to use for difficult topics like talking about family separation. Next, trauma-informed care. Over 80% of patients with substance use disorder report trauma, which is defined here as trauma resulting from an event, something that's experienced by an individual that is seen as physically or emotionally harmful and has effects on their functioning. And it's important to note that individuals may experience the same event differently. And while one individual may walk out of that same event with trauma, others may not. It's highly specific to each person. It follows that a trauma-informed approach realizes the widespread impact of trauma, recognizes the signs and symptoms in individuals, and responds by creating a system that incorporates this knowledge of trauma into every aspect of care. One of my colleagues likes to refer to this as universal precautions. We treat every bodily fluid as if it may be contaminated with an infectious disease. Yet, in spite of the widespread prevalence of trauma, we have not yet adopted these universal precautions in working with our patients. Trauma-informed care has 4 key components, which we'll walk through briefly. Realizing that trauma is widespread, and this can happen through staff training and really thinking about your care pathways in areas that may be re-traumatizing for individuals. Recognizing trauma in individuals, both your patients and your employees or the members of the healthcare team, using screening in a formalized way for patients, providing staff support, and also understanding that information is not a privilege, that patients and our team members may not be ready to share that traumatic experience with us, but that we can be available when they're ready to share. Responding to trauma includes fully integrating trauma-informed care into our policies and practice. This can be having a safe environment, security where needed, putting trauma-informed resources out on display, and even meeting patients on equal footing. Instead of having a patient undressed and in a hospital-issued garment, meeting them fully clothed at the same level in a clinical setting. And finally, resisting re-traumatizing, really including patients in their own care planning, asking them to partner with us to identify what may be concerning or re-traumatizing for them, and also celebrating their resilience. Trauma-informed care could be a talk in and of itself. Here are a few resources that I really like to use in helping to shape a trauma-informed approach to care. And the Region 9 Perinatal Quality Collaborative has some amazing trainings available locally here in the Southeast Michigan area. Harm reduction is a pillar of substance use treatment. It's a practical approach to working with people who engage in behaviors that carry a risk, and it can be life-saving in meeting people where they are. Well-known examples include things like needle exchange programs, safe use sites, administration of naloxone, or just making sure individuals have a parenting plan before using or that they're not using alone. Harm reduction really shifts the conversation from we need to get people to do the right thing to we need to get people to come back safely. And I think this is quite different from how I trained as a physician and really requires this immense frame shift in how we come to care. And patients notice and feel it when we meet them where they are. And then finally, social drivers of health. 80% of health outcomes are driven by non-medical factors, which is humbling as a clinician to realize that what happens outside of the office and the hospital has a greater effect than any clinical care that I provide in the four walls of a clinic or a hospital. Social drivers of health are quite broad. They often include domains that clinicians are not prepared or trained to address. Things like economic stability, helping people to find a job, education, healthcare financing and insurance, neighborhood and built environment, having a safe place for people to exercise, social and community context, helping individuals to find connection, and psychological health. Interprofessional teams play a critical role in addressing care for birthing people with substance use disorder. And you have some extra team members that you can add for birthing people beyond the usual folks. Social workers, of course, provide a critical role. The maternal infant health program is available along with WIC to help with material needs and also home visiting. Peer recovery coaches can help support patients and to really help to alleviate these needs. But also, I would argue that clinicians have a role to play in addressing unmet social needs. Traditionally, clinicians have just followed the top row of this figure. The patient comes for care. They may have some unmet social needs, which we don't really notice until the patient doesn't come for care. And then we see poor outcomes. But instead, when the patient comes for care, we can lead the charge on assessing for unmet social needs. And once identified, provide two care pathways. The first is assistance, providing resources for unmet social needs, giving someone a ride voucher if they have transportation insecurity, or helping to connect them with the services they need to fix the car. At the same time, we can adjust care to make it more flexible and more accessible, using virtual visits when patients can't get a ride. And in doing so, we improve trust and we improve access, overall leading to better outcomes. While we absolutely need our colleagues in the community and in the social services space, we too have a role to play. All right, with this context, we can now delve into identifying substance use in pregnancy. This case is of a clinic. Stork clinics and OBGYN practice, they provide care for a diverse patient population, including patients who are rural and urban, with private and public insurance, and with differing racial and ethnic backgrounds. They've always collected a urine drug screen from their patients at the first pregnancy visit to be fair to everybody. To increase efficiency, the prenatal labs are typically ordered prior to the first prenatal visit. So when the patient checks in, they go immediately to the lab, their urine and blood is collected, and then they have their first prenatal visit. What this means is most patients are not even aware that their urine is being tested. So, is this clinic providing screening or testing? And do you think that this is truly an equitable policy? And what concerns might you have about this approach? So, I want to start by differentiating drug screening versus testing. Verbal screening is a series of questions that we ask patients about their substance use. And this is what ACOG, the American College of Obstetricians and Gynecologists, recommends for all patients in pregnancy. And in fact, the use of universal verbal screening has been found to reduce inequities in urine drug testing. Testing, in contrast, is a method to detect or confirm substance use, often done through urine. And this should not ever be done without the patient's consent and without sharing the implications of a positive screen with the patient. So, when we're talking about verbal screening, there are several tools that you can utilize. The NIDA Quick Screen is what you see on the left, and this is what we've been using here at the University of Michigan. This screen provides a really clear connection between a positive response and action for patients who are continuing to use substances in pregnancy. It helps us to know who needs direct referrals now. I will say that we have made some modifications to the screen. We ask both about the past year and since becoming pregnant to help give us that temporal information. And given the increase in use of marijuana with its legalization in the state, we also ask about cannabis use. The tool on the right is often used by pregnancy practices, often labeled the 4 or 5 Ps, and it asks about substance use in parents, partners, in the past, in the present, and then also in pregnancy. And as you're deciding which tool you are selecting, there are some things that may push you in one direction or the other. Often, one of these tools is built into the electronic health record, which can facilitate easy data collection and even can allow that tool to be pushed to your patients prior to visits. Also, thinking about your staff's comfort with screening and referral and the differences in these tools can be helpful for selecting between them. No matter what tool you select, it really is critical for screening to be done in a supportive, trauma informed, resource first way. And some of those principles include starting with why. We include language that substance use can affect people's health and well being, and we want to help patients who are continuing to use substances in pregnancy. It's important to normalize the screening, to ask these questions of every patient, and also share that patients don't have to answer if they don't want to. And it's also important to be true to your word. If you're saying that everyone is screened, make sure that everyone is screened. And building the screening into routine workflows, whether that's a prenatal intake or a prenatal new patient template, make sure that we ask everyone. Electronic screening is all right. If you have a way to push questionnaires to patients in advance of the visit, this can be a great way to get information in a private environment where patients aren't asked to disclose information in front of a partner or in front of a support person who comes with them to their visits. But it's also important that these screens don't get lost in the EHR ether and that someone follows up on those positive screens. ACOG recommends using the SBIRT approach, screening with brief intervention and referral to treatment. And it is important to share with patients the potential implications of positive screening, including Child Protective Services involvement, and to connect them with resources like social work to help understand what this means. And then finally, revisit screening if needed. Receiving information is a privilege. And if patients aren't ready to share, perhaps after future rapport building and creating that relationship, they may be willing to share with you in the future. All right, so what about urine drug testing? Again, this could be a full lecture in and of itself, but briefly, urine drug screening typically detects specific substances. There are a variety of types, the UDS 6, 8, and there is an upcoming UDS 10. UDS 6 and 8 will not detect medication for opioid use disorder, methadone or buprenorphine, and it also will not detect alcohol. That needs to be added on as a separate urine metabolite. A new drug screening is coming out that will detect buprenorphine and methadone, but currently those tests in most facilities need to be ordered separately. In contrast, gas chromatography identifies individual substances. It is important, however, that you know how to interpret gas chromatography because you can see a variety of metabolites and also have some cross reactivity here. I just want to emphasize again that urine drug testing should always be done with consent and in compliance with state laws. So, when does a urine drug test help? Urine drug testing can help when there is a positive verbal screen to confirm the substances that are currently being used. This is particularly important in a time where we are seeing contamination of our drug supply with fentanyl as well as with xylazine. Urine drug testing can also help to confirm the utilization of medication for opioid use disorder and demonstrate that patients are successfully engaging with care and maintaining their recovery. Many facilities are actually moving towards a written informed consent process before completing a urine drug screen to inform patients of potential consequences, including CPS involvement should they screen positive. You can see one such example here, which walks a patient through the implications of both completing the screen and what might happen with a positive screen as well. It is also important to emphasize that a positive test for opioids or any substance does not equal use disorder. This just shows that the patient has used a substance, but opioid use disorder is defined as a pattern of use with signs of physical dependence and withdrawal, inability to cut down, and behavioral patterns that result in problems at work, home, and in relationships. These DSM-5 criteria are the same inside of and outside of pregnancy, and you can see that list here. Based on the criteria met in the checklist, opioid use disorder can be defined as mild, moderate, or severe based on the number of symptoms and behaviors identified on the right. I also just wanted to take a moment to mention newborn drug testing. This is most commonly performed on meconium or the first infant bowel movement, and this can detect exposure as far back as the second or third trimester of pregnancy. And this differs from infant urine screening, which just detects more recent use. Again, a positive test diagnosis here, or a positive test here diagnoses use, not use disorder. And it's important to acknowledge the notable racial and ethnic inequities we have seen in newborn testing across the country. And these have actually persisted even with universal screening policies implemented at institutions. This bar graph on the right is the result of a retrospective cohort study of over 7 years of data at a single Midwestern institution. The study crossed over before and after implementation of a universal verbal screening program. And in almost 15,000 patients, implementation of the universal drug screening did reduce inequities in urine drug testing and pregnancy. But we did not see that benefit carry over to newborn drug testing. Specifically, infants of Black patients were more likely to receive meconium screening across all categories of screens in pregnancy. So, whether moms tested positive, negative, or received no testing at all, Black patients were more likely to have meconium screens. This reflects really important systemic bias in our system that we must address, both to improve substance use treatment, but also to reduce the inequitable implementation of policies that really negatively impact birthing people and their families. All right, so once the diagnosis of opioid use disorder is made, how do we treat it in pregnancy? We'll go back to our patient Stephanie, who we're able to gain a little more history from. She shares that she's been hospitalized for overdose twice in the past year, and that since becoming pregnant, she has really wanted to stop her substance use, but she just can't. She's using multiple times a day at this point just to feel normal and manage her cravings and her withdrawal symptoms. She's lost contact with her family because of her drug use, and she really has a tough time maintaining employment because of her missed shifts due to her substance use. So, together, this gives her the diagnosis of severe opioid use disorder. As we think about treating substance use disorder in pregnancy, specifically opioid use disorder, I follow these steps. First, identifying the substance use, understanding comorbidities and contributing factors, with permission from the patient, sharing options for the next steps, really moving through the details of peripartum care, and of course, maintaining close follow up and support. But before you begin any of these things, I would recommend starting with this question: what is your main concern today? And I will say, for every patient with substance use disorder that I have seen in the Partnering for the Future clinic, I have found their top concern to be one of these two things. How is this affecting my baby? And am I going to be able to take my baby home? And until you answer these all consuming questions, it can be incredibly hard for the patient to hear anything you have to say. So start here and then move towards those next steps. Many of these steps will be intuitive to those of you who are already providing substance use care. First is to really understand the current substance use. Many of our patients have polysubstance use, and it can be helpful to use gas chromatography for confirmation because of the contamination in the drug supply, as we discussed before. I think that understanding patients' origin story of their substance use is critical for helping their path to recovery. And it also provides a moment of connection and a relationship building experience between you and the patient, and often the support people who are with them. Also, understanding what have they tried before for treatment? What has recovery looked like in the past if this has been part of their life? And what has their experience with the healthcare system been? How are they coming into this moment with you today? I just wanted to highlight some of the key substances that we need to keep in mind in our polysubstance population, and some of the key effects that we can see from them in pregnancy. Stimulants with preeclampsia or high blood pressure of pregnancy, abruption, cardiac issues, growth restriction. Alcohol is a critical one with fetal alcohol spectrum disorder, benzodiazepines, cannabis, and tobacco. And across many of these, you see low birth weight and growth issues, which leads us to do additional testing later in pregnancy. Next, understanding comorbidities and contributing factors. In particular, in pregnancy, we want to be aware of cardiac conditions given the changing pregnancy physiology, and also infectious disease risks so that we can mitigate risk of transmission to newborns and also help to engage mom in treatment in this critical time. 80% of patients at the Partnering for the Future clinic have a comorbid mental health condition. Given that, it is critical to have a robust mental health team available. I'm fortunate in PFF to work hand in hand with a psychiatrist and a behavioral health consultant who's able to provide therapy. If you do not have these resources at your elbow, MC3 is available to help with mental health concerns in the perinatal period. And finally, we spoke about social drivers of health. Really understanding barriers and supports for individuals can help us to both overcome the challenges, but also leverage those supports for success. I think this quote from Alice Miller really sums it up. What is addiction really? It's a sign, a signal, a symptom of distress. It's a language that tells us about a plight that must be understood. And through comprehensively caring for both the medical piece, but also the mental health and social support, we can really start to overcome the patient's challenges. All right, so we have all of the right context. Now it's time to get into options. And again, here it's really important to make sure that the patient is ready for that next step. Your goal is for them to feel comfortable and safe and want to come back. And if now isn't the time that they're ready to talk about treatment, that's okay. You can let them know that you're here when they're ready. The preferred option for treatment in pregnancy of opioid use disorder is medication for opioid use disorder. This is recommended by all national maternity care societies and is associated with lower return to use and improved outcomes when done in conjunction with prenatal care. In fact, one study showed that patients who maintained medication for opioid use disorder, whether that was buprenorphine or methadone, um, this was 97% effective in preventing overdose. It is very rare in medicine that we get such a great effect. Some important counseling points are that MOUD is not replacing one drug with another. We would never speak in this way about another chronic disease like diabetes or hypertension. And so, really emphasizing that chronic disease model, both for patients, but also as they communicate with their support networks. Providing anticipatory guidance about how MOUD is affected by pregnancy physiology. Dose requirements may increase over pregnancy, and it is important to treat to increasing withdrawal symptoms or cravings. And with that, dose is not related to neonatal opioid withdrawal syndrome. Often my patients will talk about wanting to reduce their dose of methadone or buprenorphine in order to decrease the effect on their neonate. But in fact, the dosing is not related to opioid withdrawal syndrome. And so medication should be titrated to the patient's symptoms, not some perceived lower threshold of affecting the baby. The three key options for medication for opioid use disorder are the same in pregnancy and outside. The majority of the data to date comes from methadone and increasingly from buprenorphine, with emerging data coming on the safety of naltrexone as well. The considerations for these medications are the same in pregnancy and outside, with a few key things to consider. For methadone, the rate of neonatal opioid withdrawal is higher than for buprenorphine. Rates are reported at 60 to 80% for methadone versus 20 to 40% for buprenorphine. Naltrexone, as I mentioned, has less data to date, but we do see the lowest rate of neonatal opioid withdrawal, which makes sense with the mechanism of the medication, with rates lower than 10%. Just taking a deeper dive on this comparison, just like in the non-pregnant population, methadone's advantages include structure and routine, and also the benefits of this medication in the setting of increasing fentanyl use, where methadone may be more effective for making that transition to medication support. But methadone requires transportation daily to a clinic, and so this should be considered as you're helping patients to make their selection. There's some emerging data on the benefits of buprenorphine, including reduced congenital malformations with first trimester exposure. This comes from a large retrospective study that used Medicaid claims data from 2000 to 2018. The study included over 13,000 pregnancies and used quite advanced analytics to discover a lower risk of congenital malformations with buprenorphine versus methadone. The relative risk was 0.8, which translates to one less congenital malformation for every 100 patients treated with buprenorphine versus methadone. We have also seen some benefits for neonates. Lower neonatal opioid withdrawal syndrome has been shown in two studies, or two main studies. This includes the MOTHER trial, which was a double-blind, double-dummy, flexible dosing RCT of buprenorphine versus methadone. The study was international, included 131 participants, and found that lower rate of neonatal opioid withdrawal. Unfortunately, due to its size, the study was underpowered to detect other neonatal effects. Additionally, a large retrospective Medicaid-based claim study done by the same group that assessed for congenital malformations included 2.5 million pregnancies. And this study found not only lower rates of neonatal opioid withdrawal, but also preterm birth, small for gestational age, and low birth weight with equivalent maternal outcomes. Now, that said, these data are insufficient to support switching from one form of medication for OUD to another, and there are multiple reasons why. First, the majority of this data is retrospective in nature, which limits our ability to interpret it. We can't fully account for disease severity, for psychosocial factors. And in addition, these studies look at one form of treatment compared to another. This might miss patients who tried to initiate one of the medications and couldn't continue, or who had more severe disease. And finally, these retrospective studies are done in insurance claims data in patients who had stable enrollment prior to pregnancy. So this is a relatively stable population who may be different from other patients seeking treatment. In short, we have a lot to learn. Also, focusing just on the neonatal effects really misses an important component of this treatment. This is a quote from a commentary on the second of those large retrospective studies. And in this paper, the authors noted that rarely do clinicians sit down with a pregnant patient with OUD to discuss options and benefits and find that they've had no prior positive or negative experiences. Patients know what the best treatment is for them. And the ultimate treatment decision must be the result of shared decision making rather than promoting one medication over another. In other words, the best medication is the one that will work for the patient in front of you. So, if these medications for opioid use disorder have some potential adverse effects, why not recommend medically supervised withdrawal? No medication is better than the risks of these meds, right? Data and guidelines are clear here that this is not the preferred option, though it's actually not for the reason you might expect. Many believe this is not the preferred option due to an association between withdrawal, fetal stress, and fetal death. However, these findings come from two case reports from the 1970s, including one case report that included serial amniocentesis to measure catecholamines. You know what causes fetal stress? Sticking a needle through the abdomen multiple times in the pregnancy. Recent data has actually not confirmed this association. Instead, medically supervised withdrawal is not recommended because it doesn't work. It's associated with a higher relapse rate, 60 to 90%. And with that, a lower rate of engagement with prenatal care, higher rates of infectious disease, accidental overdose, and obstetric complications. These are all things that can be prevented with medication for opioid use disorder. If initiating buprenorphine, the process is very similar to non-pregnant individuals. Patients should be in moderate withdrawal before initiating, ideally with a COWS score of greater than 12. Medications can be used to manage withdrawal symptoms, and these are all comparable to what's used outside of pregnancy, with the exception of NSAIDs for muscle aches and joint pain, which should be avoided in the first and third trimester, particularly after 32 weeks, to avoid closure of the ductus arteriosus, and considered really only if other agents are ineffective for short courses in the second trimester. If initiating buprenorphine, it's important to consider the location, home, outpatient, or inpatient. Things to keep in mind are the gestational age. It is our practice here at U of M that we bring patients inpatient if they are greater than 28 weeks, although that is not the case for all facilities, and home induction can be safe in the third trimester. Disease severity may need to be considered and the support patients need in making that transition. And then finally, the patient's ability to initiate at home, including their stability of living situation. There are a variety of protocols that are used, the traditional protocol, but increasingly microdosing and even macrodosing, and helping patients get ready for induction, including sharing expectations, supports, and next steps. This is just an example of a traditional protocol from SAMHSA, which can be used to help patients initiate buprenorphine and is used by many obstetric care providers. And we're fortunate to have a nurse who's able to call patients throughout those first few days and really help them with titrating this process. We've mentioned the team throughout this presentation. I just want to highlight the variety of additional supports that patients can lean on as they move through their transition to medication for opioid use disorder and into their recovery. It's important to set expectations for the duration of care and really use a trauma-informed approach. Letting people know what's coming is part of that trauma-informed care. In the prenatal care, this can often largely mirror what routine patients are receiving with a few additions. Focusing on screening, including trauma, IPV, and social drivers in every trimester can help to account for changing needs. And then ensuring infectious disease screening is completing, particularly looking out for hepatitis C. This should be done in the first trimester and again at 28 weeks, with a consideration of screening at 36 weeks if patients have ongoing use. Care delivery can be modified, including the use of streamlined visit schedules if patients have difficulty coming to clinic, and telemedicine when in-person visits aren't needed. The plan for urine drug screens should be discussed. This should be used as a tool for recovery, not policing, or not as a punitive tool. And you can use shared decision making to develop a plan with your patient. And then fetal assessment is an important part of surveillance. We recommend a growth ultrasound at 32 weeks for patients with ongoing use or who are receiving medication for opioid use disorder. We start non-stress tests weekly at 32 weeks for patients who are receiving medication for opioid use disorder, and then recommend twice weekly testing for patients who have continued ongoing substance use. We've mentioned CPS several times, and I just want to emphasize that beginning those conversations early and often is critical. We ensure that every patient coming through the PFF clinic meets with CPS. We encourage these meetings early and often. We tell patients that this helps them to know the rules of the game so that they understand what it takes to be able to bring their baby home at the end of pregnancy, and takes away a bit of the black box feeling that many individuals have. We try to provide support for parenting to really help reduce family separation. This is an example of our pregnancy roadmap that helps patients to know exactly what to expect at every stage of the pregnancy and the options they have for education and social support. For peripartum care on labor and delivery, it's really important to address pain management. Patients should absolutely continue their medication for opioid use disorder and avoid partial agonists on the labor floor for pain management. In preparation for birth, an anesthesia consult can be really helpful, as pain can be more difficult for patients who have ongoing opioid exposure. Opioid-sparing protocols should be the mainstay of treatment, but short-acting agonists are acceptable, and in fact, patients may have higher need for agonist medications while they are on labor and delivery and in the immediate postpartum period. And depending what's available at your facility, long-acting regional analgesia and tap blocks may be helpful if patients require cesarean birth. If you want more information, this QR code here will take you to a whole suite of materials on peripartum pain management designed in collaboration with the Obstetrics Initiative and Open, including specific recommendations for patients with opioid use disorder. We would be remiss not to mention neonatal opioid withdrawal syndrome. This is a presentation of withdrawal symptoms in infants shortly after birth due to in utero exposure to opioids. And it's important to note that this is not addiction. Addiction is a pattern of behaviors which infants are not able to exhibit. NOWS is treatable and short-lived. Its timing does depend on the half-life of the opioid exposure. And so most of our infants will have a 72-hour observation period postpartum. Symptoms largely mirror those that we see in adult patients. And we mentioned the rates being greater with methadone compared to buprenorphine. Previously, we used to sequester infants in the NICU and treat to the Finnegan score, this complicated algorithm that you see on the left that was quite subjective. This assessed withdrawal symptoms and relied really heavily on pharmacologic treatment. In recent years, a new approach, Eat, Sleep, Console, has emerged. It uses the stoplight method you see on the right and leverages the behaviors that parents do best, non-pharmacologic things to help baby feed, soothe baby to sleep, and provide other strategies for comfort. Eat, Sleep, Console has been remarkably effective. Here you can see the results of a cluster randomized controlled trial published in the New England Journal in 2023 in 26 hospitals with over 1,300 infants. And what you see is that compared to the traditional Finnegan scoring with pharmacologic intervention, the time to discharge was reduced by almost 7 days with equivalent safety measures. If you have questions on Eat, Sleep, Console or need handouts or protocols to share with your teams, please don't hesitate to reach out. And just a brief note on postpartum care. Again, setting expectations for pain management and the importance of opioid-sparing protocols is critical for patients. Addressing risk reduction topics is also crucial. The greatest risk of return to use and overdose is postpartum. Make sure all patients have a naloxone prescription and collaborate with MIHP and your social work team to help patients ensure they have a plan of safe care. Make sure to provide lactation support and contraceptive counseling and help individuals in their transition to parenthood. We often do frequent check ins with our patients, not waiting until the traditional 6-week postpartum visit to see how they're doing. And we actually have shifted to providing care up to 1 year postpartum in PFF in recognition of the high rate of overdose and return to use in that year postpartum. And so I will just emphasize connect, connect, connect. Remain in touch with your patients. If you need support in caring for your birthing people with substance use disorder, the Partnering for the Future Clinic is here to help. We are at the University of Michigan in the Von Voigtlander Women's Hospital, and we care for patients with opioid use disorder, substance use disorder, and chronic pain. We have an interprofessional team that provides comprehensive wraparound services. And we can provide care in 3 key ways: consultation, just helping your patient to have a care plan that they'll return to you with; co-management, working hand in hand to manage; or complete referral, where we'll happily take care of patients up to 1 year postpartum. You can fax a referral to us or just email me, and we'll make sure that we get your patient in. So I hope today's presentation has given you the tools to help birthing people with substance use in pregnancy overcome significant barriers to care and begin their path to recovery. Though no one can go back and make a brand new start, you can help your patients and their families to make a brand new ending. Thank you so much for your time today. Please do not hesitate to reach out with any questions. I look forward to your questions.
Thank you so much, Alex. This was a fantastic presentation. I'm going to share my screen so everyone can see the CE information. I also posted it in the chat. And again, it will be sent out at the conclusion of the webinar later today or early tomorrow morning. So folks can also get it in their email. Let me just check the Q&A. I know you touched on the Partnering for the Future Clinic. There's a question: can we refer patients to U of M for SUD treatment if we don't have the resources and personnel in rural northern Michigan? I'm assuming they probably would need some telehealth. I know we've talked about that, but can you just share kind of where that's at?
Absolutely. So we are working on a more formal telehealth program to help care for patients in the UP. In the meantime, we are happy to provide consultative services, see the patient for a one-time or ongoing telehealth consultation, as long as we can work with an in-person provider to make sure that some of those services that we can't deliver through the phone can be managed. So the best way to arrange that would just be to send me an email, and then we can help to collect the patient information in a HIPAA compliant way and get them connected with our services.
Thank you. I know we just have a few minutes before we're at 1 o'clock. So if someone has a lasting question more in the chat, we can take this one. What are your go-to antidepressants that you feel are safe to offer pregnant patients with substance use disorder with co-occurring depression?
This is a great question. And I will say, if this came up in a time that was outside of our webinar, you could actually complete an MC3 consult, and they would be able to get back to you same day with a response. I'll also refer you to the MC3 psychopharmacology cards, which go through each of the psychotropic medications, their safety in pregnancy and lactation, how to start them, and how to titrate the medications. In a patient who has never been on antidepressants, and we are starting to address her depression, and that was the only mental health concern for her, I frequently use Lexapro. It tends to be well tolerated with few side effects. It has a great safety profile in pregnancy, and many of my patients have been quite successful in that. That said, I find that it is rare that a patient has isolated depression with substance use disorder in pregnancy, and often we are thinking about much more complex medication regimens that address PTSD, anxiety, other elements. And in those cases, I'm often working hand in hand with the psychiatrist in the PFF clinic to come up with a more nuanced plan.
But sounds like it could be a great time for accessing some of those other resources, or even a, clinician to clinician consult too.
Absolutely.
One more question and then we'll end for today. What do you do with folks who refuse screening questions and or screening?
It's a great question. I first try and prevent refusal by how I bring up the question. So, those principles that we talked about, these are questions we ask every patient. If someone responds to these in a positive way, then I would hope to connect them with resources. And we try to do this across all of our questions for mental health, social drivers, etc. That said, if someone says, I don't want to answer that, I say, I absolutely understand. Often this is at our first meeting, and I'll say, you don't know me, and these are really intimate questions. Would it be okay if I revisit this question in the future? The reason I ask this is because this is really important information for taking care of you and taking care of your baby. And with their permission, I put it on my checklist to revisit in a future visit.
All right. Well, it is 1:01, so we will wrap up for today. Thank you so much again, Alex. That presentation was phenomenal. We also recorded it, so it will be available on our YouTube channel for future viewing. If anyone is interested, again, you will get the CE information as well in your inbox. But thank you so much, and everyone have a great day.